everyone. In the interest of time, we will start. Welcome to this session, HPB parallel session. Just to introduce ourselves, my name is Carrie Liu. I am from the University of Arizona.
My name is Jens Mittler. I'm from Germany.
And Jun Shindu from Tokyo, Japan.
So we go ahead and start with our first presentation, which will come from Ohio. Dr. Yutaka Endo is presenting a paper on the use of telemedicine in GI cancer patients. Dr. Endo, please.
Hi everyone, my name is Abdullah Altaf. I'm a research fellow at the Ohio State University. I'm really pleased to be here to present our research study on effect of telemedicine use on medical spending and healthcare utilization among patients with gastrointestinal cancer. So there have been multiple studies in the field of primary care and mental health care that have demonstrated that telemedicine use was associated with increased outpatient care utilization and lower prescription orders without any increased incidence of adverse health events. For GI cancer patients who usually require multimodal treatment and complex in-hospital surgical procedure, the impact of telemedicine use has been relatively unexplored. Therefore, in the current study, what we did was we characterized factors related to telemedicine utilization among patients with GI cancer. Additionally, we sought to compare healthcare utilization, workplace productivity, and medical expenditures among patients, among GI cancer patients. So for this study, we utilized the MarketScan database. We included GI cancer patients from 2013 to 2020. The primary outcomes of interest were total number of clinic visits, ER visits, inpatient visits, medical expenditures, which included both total and out-of-pocket costs, and missed work days. Missed work days were calculated by the formula shown on the slide. And in the study, firstly, we identified the factors that were related to telemedicine use, and then comparison of outcomes were made following propensity score matching. So coming to the results now, perhaps not surprisingly, there was a huge surge in telemedicine use after COVID-19 pandemic. And this is what we wanted to look into in this study, the impact of this surge on healthcare utilization among patients. So on multivariable analysis, we found that GI cancer patients who utilized telemedicine were more likely to be younger, female, more likely to be active full-time worker, resided in rural areas, and had a diagnosis of HPV malignancy. After performing propensity score matching on certain clinical demographic factors, we found that telemedicine users were more likely to have increased total clinic visits and reduced missed work days. Although there was higher healthcare expenditure, but there was no difference in monthly out-of-pocket spending. Of note, among surgical patients, telemedicine use was correlated with higher ER visits. But among patients who received chemo or radiotherapy, there was no difference between the two groups. So from these results, we can say that telemedicine use was associated with increased outpatient clinic visits and reduced work days without any added out-of-pocket spending. Among surgical patients, telemedicine users tended to have higher ER visit, which can be explained by their need for physical examination following surgery, emergency admission, or also their high-risk patients needing more follow-up. So we need more study to optimize telemedicine use among these surgical patients. Thank you so much, and I'm happy to take any questions.
Hi, I'm Mark Stabies from Holy Cross in Silver Spring, Maryland. I've been asked to be the primary discussant for this paper. Thank you for this paper. Unfortunately, it did take a pandemic for us to use telehealth more. I think the transition was much easier. I saw the data that apparently 85% of the American households in 2000, at the start of the pandemic, had a smartphone. Yeah. So it's much easier to transition. I can't only imagine if it was only 50%. Thank you for the financial burden to patients you've outlined, but also what we don't really see that your paper did note is the time burden is less for telehealth users. My question to you, though, is anywhere in your data, we do know that according to your data, there are more ER visits for patients who did have that use telemedicine. But did that mean a higher readmission rate, or did the ER visit supplant the need for readmission?
Okay, so we also did this analysis in our paper, and we didn't see any difference in the incidence of the percentage of readmission following surgery between those patients who used telemedicine and those who did not. If I remember correctly, it was 9% for those who used and around 8% for those who did not. And it was statistically insignificant. So yeah, thank you for that question though. Yeah.
Great, thank you.
Thank you so much.
The next paper is from Emory, and Dr. Megawa is presenting his analysis on robotic versus laparoscopic cholecystectomy.
Thank you for the opportunity to present our research. So, we're presenting robotic versus laparoscopic cholecystectomy as a comparative study using NGЯOC database. I have no financial disclosures. Sorry. Let me just. The benefits of minimally invasive surgery is well recognized, is associated with less pain, lower risk of infections, complications, and also mortality, and also a shorter length of stay. However, these benefits are lost once the conversion to open occurs. And is detrimental for the patient, hospital system, and the surgeon as well. One of the most consistent outcome and advantages of robotic surgery over laparoscopic is a lower conversion rate to open, and that's demonstrated across different specialties and procedures. A recent study suggested that robotic cholecystectomy is associated with a higher risk of a common bile duct injury compared to laparoscopic surgery, raising concerns of the use of a robotic platform for cholecystectomy. In this context, we analyzed the National Surgical Quality Improvement Program database, evaluating the patients that underwent cholecystectomy, robotic or laparoscopic, during the year of 2022. Our primary outcomes were Clavien-Dindo complications grade 3 or more, and conversion to open, and secondary outcomes, readmission, reoperation, length of stay, longer than 24 hours. These tables show our demographics. The robotic cohort have a higher number of African-American white patients, also increased in incidence of obesity and frailty. And however, the laparoscopic cohort have a higher number of surgeries that were done emergency or urgent basis, and a higher number of patients that had diagnosis of acute cholecystitis. However, the robotic cholecystectomy had a higher rate of chronic cholecystitis as a late diagnosis. This table shows the outcomes without controlling for other factors associated with our outcomes. And laparoscopic surgery was associated with higher risk of serious complications, conversion to open, readmission, return to the operating room, and requiring admission longer than 24 hours. Multivariable logistic regression controlling for other factors that are associated with our outcomes of interest show that robotic laparoscopic cholecystectomy was associated with a higher risk of serious complications, higher risk of conversion to open, as well as increased odds of staying hospitalized longer than 24 hours. There is no difference in terms of readmission and reoperation. Our study has several limitations that are inherited to its retrospective design. Although we perform a multivariable logistic regression, for the controlling for other factors associated with our outcomes, there is a potential of a selection bias. We had no data on surgeons' volume and the experience, also no available data on common bile duct injury and other factors that could have influenced our results. With those limitations in mind, we can conclude that robotic cholecystectomy is independently associated with lower rates of serious complications, lower odds of conversion to open, and hospitalization longer than 24 hours comparing to laparoscopic. And these findings suggest that facilitating the adoption of new technologies that can make laparoscopic surgery safer is warranted. Thank you very much.
Are there any questions from the floor?
That was a very nice presentation. I would like to ask you if it's possible that the laparoscopic cholecystectomy was performed among a much wider range of surgeons and hospitals, including less experienced surgeons, younger surgeons, and smaller hospitals, whereas the robotic surgery was limited to major hospitals with surgeons with more experience and people who could help and take over the difficult cases, and that reflects in the results.
Definitely is a possibility. Unfortunately, that's one of our limitations because this is administrative data, so we didn't have like a more granular data in terms of surgery experience and the facility volume per se. But it's a good point. Thank you for bringing that up.
Congratulations for your job. I have one comment and one question. The comment is that one main issue, and probably this is the largest bias of the study, is that we do not have data about the local condition of the cholecystectomy, the rate of acute cholecystitis, adhesions, and whatever. And this can be the reason why you have good results with the robots rather than with the laparoscopic, because probably people performing robotic surgery in this setting did it prevalently for gallbladder stones rather than other conditions. And I think this is something very important to account for this study. The question is, what about the cost of these procedures? Mm-hmm. Because I think, I don't know, probably in the USA, but in other countries, this is the main issue to implement this type of approach.
Absolutely. I think until to these days, robotic surgery is definitely more expensive than laparoscopic. And that's the reason for our study. We're trying to see what the benefit, clinical benefit of a robotic approach comparing to laparoscopic. So you have a denominator for that initial cost associated with robotics. I think if you can justify the upfront cost of some clinical benefit, you can justify the initial cost and will be cost effective in that fashion. So definitely a cost effective analysis in this kind of a study to complement the findings will be very important to follow up.
Great, thank you.
You're welcome. Thank you.
Yeah, thank you.
Our next presentation is by Dr. Kazuhide Matsushima from the University of Southern California. The title is Prospective Evaluation of Surgical Techniques for Subtotal Cholecystectomy in Patients with Acute Cholecystitis and East Multicenter Study.
Good afternoon. I'd like to thank the program committee of SSAT. So today, I'm going to report the result of multi-center study for techniques for subtotal cholecystectomy. So subtotal cholecystectomy is not necessarily a new surgical technique. It has been described long time ago, but in recent years, people start using more as one of the bailout procedures for difficult gallbladders. Today, I think the mainly two techniques has been described and people performing in those difficult gallbladder cases. One of them, which called the fenestrating technique, which is leaving the stump open. The other one is a reconstituting technique, which is closing a stump. They're a little known, which one would be better than the other one. So we as a society, we decided to conduct a prospective observational study to compare the outcome between these two techniques for the subtotal cholecystectomy. So this is a prospective observational study at two centers, mainly trauma centers, sponsored by EAST, which is one of the major acute care surgery society in the U.S., between July 2019 to June 2022. Our primary outcome was a secondary intervention after the index surgery. And the secondary outcomes include bioleak, readmission rate, and the recurrent biliary disease. In the long term, we follow up the patient 6 months and later. More than 2,500 acute cholecystitis patients, about 60% of the patients underwent subtotal cholecystectomy. Of those 127 patients underwent penetrating subtotal cholecystectomy and 35 reconstituting subtotal cholecystectomy. Of note, almost 80% of the subtotal cholecystectomy was done laparoscopic. So this is a quick main result of our study. So after the index surgery, the rate of bioleak is 32% in a penetrating technique. On the other hand, about 8.6% in the reconstituting technique. Oftentimes, those in the bioleak require ERCP, so not surprisingly, the rate of a secondary intervention is much higher in a penetrating technique group, 34%. Rather the 17% in a reconstituting technique. And the short-term readmission rate within 30 days is significantly higher in a penetrating technique at 24%. On the other hand, recurrent biliary disease in the long term is significantly higher in a reconstituting technique, about 21%. So our result shows that in the short-term outcome, obviously it sounds very intuitive. If you leave the stump open, oftentimes patients develop bioleak and requiring ERCP. Rather, if you close the stump, the patient may have a higher risk of a recurrence, meaning such as recurrent biliary disease, pancreatitis, even acute cholecystitis in the remnant gallbladder. So I think right now, the pros and cons for each procedures, and whenever you proceed, I think you have to kind of decide case by case, and it's not often easy to discuss with the patient about each option, but this is something you may have to consider if you schedule difficult gallbladder cases. I'd like to thank my collaborators from 9 centers and the EAST for sponsoring this study. Thank you so much.
Right. We have time for one question.
So, I think you hit it on the head, which is when you do these and you do fenestrating, as an HPV surgeon, I'm always kind of curious why, rather than, involve some of the colleagues to help, it's easier and you lack suturing ability. I think it's part of the problem. So I think, what's the next step with this? Are you going to take this and say, now we recommend, doing more? Because I think a bioleak after, cholecystectomy is something we're trying to avoid. So what's the next step?
Yeah, I think that's always the comments, and especially our colleagues in the HPB. Simply sometimes they said, you don't need to do a subtotal cholecystectomy, but I think the laparoscopic cholecystectomy is one of the most commonly performed surgery in the U.S. And I think those are the surgeons with specific expertise not available during, like, for example, middle of the night. So I think that the safety is always the most important thing. But I think that the next step will be, again, there's a couple of things you can come from here. is that something like, almost like a bile duct injury, you always have to call the expert surgeons to, troubleshoot in this situation? Or because the ERCP success rate is very high, as you know. So I don't know what's the consequence of ERCP. Obviously, that's not the, free ride, but again, what's the impact on that real patient outcome and the cost? Those are the things. And also, as from a technology standpoint, I'm working right now. Even if you had the patient, you end up doing a penetrating cholecystectomy, there might be some technique nowadays collaborating with the IR people or the area of medicine. We may even just not to have a bioreq with a certain technique. So that's something I'm working on right now. But again, those are all preliminary things. So I'm hoping just to present those results in the next year or two.
I have a doubt on the figures.
Okay.
You had put 2,500 acute cholecystitis, 79.3% laparoscopic subtotal cholecystectomy, but only 150 were there in the two groups. What happened to the rest?
So let me clarify. So about out of those 2,500 patients, about 60, the 6% only required subtotal cholecystectomy. So meaning 94% of the patients.
No, but you had put 79.3 subtotal cholecystectomy.
Yes.
I remember on the.
Yes. So sorry, it was it's not very clear. So out of 162 patients who underwent subtotal cholecystectomy, of those, about 80% had a laparoscopic subtotal cholecystectomy.
Okay, I got that. No.
Okay. Thank you. Thank you very much. So the next presenter is Dr. Roche from the Indian University. He's going to be talking about natural history and the implications for management of type 1 choledochal cyst in adults. Please start your presentation.
Good afternoon, and thank you to the organization for the opportunity to present our work. I have nothing to disclose. So choledochal cysts are classified according to the TODANI classification, and type 1 is a fusiform dilation of the extrahepatic biliary tree, with the main strengths being that this is the most common subtype, representing about 79 to 80%. The weaknesses is that there's a high malignancy risk, up to 15%, and this is an indication for surgery. So our group has already published on choledochal cyst in 2010, mostly on type 3 choledococele. So we updated our prospective series from 1990 to 2023, including only TODANI type 1. The primary outcome was malignancy. The secondary outcome was morbidity of surgical resection. We included 100 patients with a median age of 41 years, and 89% had symptoms. The most common was right upper quadrant pain, biliary colic type symptoms. 16% had pancreatitis, and 11% had cholangitis on presentation. The median diameter at diagnosis was 22 millimeters. 83% of patients had an ERCP, with the most common finding being an anomalous pancreatobiliary ductal junction that was present in 83% of patients, which was significantly higher than in other biliary dilation. The malignancy rate over time was 6%. That represented only 6 patients, and 5 of them had been diagnosed as a child and treated with a cyst bypass and not with a resection. The morbidity of surgical resection was 50% for overall complication, 40% of clavien-dindo 3 to 5, 15% of clinically relevant bile leak, 22% of anastomotic stricture over time, and 5% had a retained cyst in the head of the pancreas that subsequently required a Whipple surgery. So type 1 choroidochocyst can become malignant, but the rate in our series was significantly lower than previously reported, mostly in pediatric population. It was only 6%. And that's going to be very controversial, but an extrahepatic biliary dilation at a late age and without an anomalous pancreatobiliary ductal junction is probably unlikely to be a type 1 choroidochocyst. So the implications in management, if it's diagnosed in childhood or early adulthood, it should be surgical resection, obviously not a bypass. And if it's diagnosed in older patients, maybe consider surveillance due to the high morbidity of surgical resection. And this is game 7 for the Pacers, so go Pacers.
Thank you very much. We have a discussion for this paper, Professor Steves. Okay.
Oh, I'm so sorry.
Okay.
Mei T from Washington,
Go ahead.
D.C. Nicely presented, Alex. Good to see you again. I had a couple of questions. So there's a theory that the increased risk of cholangiocarcinoma in these cysts is not just due to the biliary stasis, but also some sort of field defect. And so I have two questions. The first question is, how do you reconstruct your after resection due to hepaticojejunostomy or hepaticoduodenostomy? And the reason for that is, you know, it goes into what do you do for these patients after you resect them at Indiana University? How do you surveil them for those kind of other cholangiocarcinomas in the biliary tree from this potential field defect? Thank you.
So we do a Roux-en-Y hepaticojejunostomy, and then we do LFTs yearly. And if they increase, then we do some cross-sectional imaging.
I just had one other question. What struck me was the lower rate of cancer in your group and also the higher rate of anastomotic issues. From your data, can you see where the risk of surgery would be greater than the risk of cancer is in 40-year-olds, 50-year-olds, 60-year-olds, or 70-year-olds?
So the risk of anastomotic stricture is probably almost completely related to the risk of leak, and everybody that leaked had a stricture over time. And there's been many studies showing that the cyst, actually the biliary duct lining is different in choroidochocysts than in the normal, extrahepatic biliary tree, and that's why they're having so much leakage. Now, the cutoff, I would say that if it's somebody in their late 6th decade or 7th decade, probably not a good idea to have them go through that, but it's just my opinion.
You had mentioned that you suspect a diagnosis when you have the abnormal junction, which is absolutely correct. But I would put 2 points which you should alert you to that this is a colorectal cyst. A bile duct which is dilated significantly without intrahepatic biliary dilatation, and a bile duct that is significantly dilated without a rise in bilirubin. These two should lead you to suspect a colorectal cyst.
I completely agree with the first statement. With the second statement, a significant number came with cholangitis and they had increased.
But if they don't have jaundice, but they have a dilated duct, you should again suspect.
Thank you so much.
Okay, thank you very much.
Thank you very much. So the next presentation is on cancer surgery in flagship versus non-flagship hospitals, and presenting is Dr. Munir from Ohio.
Hello everyone, my name is Zaid Rashid and I'm from Ohio State University doing research fellowship over there, and I am here to present the topic of impact of hospital flagship system affiliation on surgical outcomes following complex cancer surgery. We have nothing to disclose. Regionalization of surgical care has been associated with improved clinical outcomes. However, the impact of hospital mergers and system affiliations has not been assessed for oncological procedures. Oncology services may be susceptible to brand sharing, as cancer service lines are frequently prioritized as a top-line revenue generators, Additionally, local hospitals often seek to affiliate with flagship cancer hospitals to attract local market shares. Previous studies have primarily examined the benefits of hospital affiliation with flagship system in terms of outcomes and financial performance before and after affiliation. Therefore, the objective of current study was to assess variation in clinical outcomes and financial expenditure across hospital flagship systems, flagship hospitals, and flagship affiliates in major hospital referral regions. We used data from Medicare and Agency for Healthcare Research Quality List. Patients who underwent complex cancer surgery were included. Flagship hospitals were defined as the largest major council of teaching hospitals and health systems, COTH hospitals, with the highest combined medical and surgical patient volume, while the system encompassing the flagship hospital was characterized as flagship system. The primary objective included 30-day mortality, while secondary objective included 30-day readmission, perioperative complication, extended length of stay, index, and 90-day post-discharge expenditure. Before propensity score matching, we had around 160,000 patients who underwent complex cancer surgery, and after matching, we had around 55,000 patient pairs. Majority of the patients underwent colorectal surgery. The total centers were around 3,500. The flagship system were around 1,113, among which 33 were the flagship hospitals. This figure demonstrates predicted 30-day mortality rates against some of comorbidities and shows that flagship hospitals had lower predicted 30-day mortality. In fact, on multivariable analysis, this decrease in 30-day mortality in the flagship system was mainly driven by the main flagship hospital. However, it is worth noticing that this flagship hospital was also driving the healthcare cost to the higher side. In conclusion, flagship hospitals are the primary drivers of lower postoperative mortality, although at higher cost. Affiliate hospitals have a modest difference in mortality and cost versus non-flagship hospitals. Consolidation in flagship systems may improve quality of care, yet benefit is largely due to the hub hospital. Thank you, and I'm open for questions.
Thank you for the presentation. Are there any questions from the floor?
Hey, good afternoon. Prakash Pandali from the University of Kentucky. That was really well presented. I guess my question here is, as systems are, more and more pressure to affiliate with sort of tertiary care academic medical centers, flagship hospitals, as you've described, what can the leadership within surgical organizations and in those departments do to raise the quality of care? For example, if I'm a surgeon in a affiliated hospital, and I run into a difficult case in the middle of the case, what do you do? Do you transfer that patient at that moment? How do you facilitate those types of things?
Yes, that's a very good question. Actually, that's what the main point of the presentation, that right now the flagship is more being considered as a branding. Like hospitals are more driven towards brand themselves as a flagship system rather than focusing on their quality. So after focusing, I think the flagship system should be built in such a way that they should create some quality metrics, that some standards should be met. So the hospitals that are allowed to enter in the system, they should be mandated to follow those protocols. And again, that is a really good point, that protocols should also be built where if there is some difficult case at a lower center, which is a flagship center, and then that protocol should be followed for the transferring of the patient as quickly and as efficiently as possible.
Thank you very much.
Thank you.
For the sake of time, we have to move on.
So next presentation is by Vishnu Prasad from the Jawaharlal Institute of Postgraduate Medical Education. He will be speaking about GSF and erythropoietin combination therapy in upper GI bleed with underlying liver cirrhosis, a randomized controlled trial.
Good evening. The topic for my presentation is granulocyte colony stimulating factor and erythropoietin combination therapy in upper gastrointestinal bleed with underlying liver cirrhotic patients. It's a randomized controlled clinical trial done in Department of Surgery and Department of Medicine, JIPMA, India. So I have nothing to disclose. So management of variceal bleeding is complex, and to prevent recurrent bleeding means you need to treat the underlying cause. This means you need to liver transplantation in many of these patients, and in a resource-limited setting, this may not be possible, and we may have to resort to other method of liver regeneration technique. And in this context, exogenous administration of cytokines, so which may facilitate transfer of the mobilization of the bone marrow stem cells into the liver may be useful. So in this context, we did a study, so using the granulocyte colony stimulating factor along with the erythropoietin in patient with upper GI bleed patients having underlying cirrhosis, because these are the patients which are primarily managed by us. Right? So with the primary objective that it may improve the survival, and with the secondary objective that it may prevent the recurrent episodes of rebleed, and it may prevent the onset of new complication, and may improve the liver disease severity score, and also to see whether this therapy is safe. Right? So this study was done in the Department of Surgery over a period of 2 years, from January 21 to February 23rd, over a period of 2 years. So 56 patients above the age of 18 years were randomized into 2 groups. The group A receiving GCSF plus EPO combination therapy. So this therapy is given once the patient is stabilized after his upper GI bleeding episode, after 1 or 2 weeks. So GCSF is given on day 1, 2, 3, 4, 5, and then every third day over 12 doses. And the dose is 5 microgram subcutaneously. EPO is given 4,000 units every third day and 12 doses. And these patients were followed up at second, fourth day, and at first month and 6 months. So the duration of follow-up was 6 months. Initially, we had planned for 1 year. Because of the COVID situation, we could follow up only for 6 months. This is an abbreviated console diagram for this trial. We assessed 160 patients. We had to exclude 104 patients because of many criteria like the age, more than 75 excluded, patient having underlying hepatocellular carcinoma excluded, those who presented with stage 4 hepatic encephalopathy are excluded. We randomized 56 patients, group A, 28 patients who received GCSF plus EPO standard therapy, group B, placebo in the form of saline given, and these patients were followed up. 2 patients were lost in follow-up in group B. Both the groups are comparable with respect to the demography and clinical features. The most common cause for upper GI bleeding varices was underlying alcoholic cirrhosis. And if you look at the results, the cumulative probability of survival at 6 months was more in 82.1% in group A compared to B, 61.5%, but it was not statistically significant. So the mean survival time was more in group A, 160 days compared with B, 130 days. Mean delta change of MELD score, CTP score, and MELD NA score was higher in group B. Again, it was not statistically significant. But what was statistically significant was those not requiring repeat hospitalization was less in group A. The number of recurrent episodes of bleeding was less in group A. Number of spontaneous patients having spontaneous bacterial peritoneum was nil in group A. And the treatment was safe because only a few patients developed a body ache and fever. There are no significant complications associated with this therapy. Hence, I would like to conclude that combination therapy of GCSF and EPO in patients with upper GI bleeding with underlying cirrhosis, so it may prolong the survival and it may give a significant reduction in the number of episodes of recurrent bleed, hospitalization because of complication, and the therapy is quite safe. So thank you.
That was a very nice presentation. I have two questions. So I assume the follow-up protocol in the placebo group was similar to the follow-up protocol in the experimental group, so this was not a lack of follow-up on their part?
No. Only 2 patients were lost in follow-up in group B, that's in the placebo group. Otherwise, the follow-up was same. We follow each patient was assessed correctly on 2nd day, 4th day, and at 1 month and at 6 months.
That's great. What is so you mentioned the underlying hypothesis that it's maybe stem cells that actually translates into this improvement. Is there actually anything that's measured to suggest that that's true?
Yeah, actually in our study, we have not taken a liver biopsy, but there are studies in the literature which has been, one of the prominent studies is Kedar Shetty et al. So where they have done a liver biopsy and they have shown the hemopoietic stem cells, and there are 3 types of stem cells in the bone marrow: hemopoietic stem cell, mesenchymal stem cell, and endothelial stem cells, which may migrate into the liver and they may help in regeneration. And this study from the Kedar Shetty et al., they have taken biopsy and done an immunohistochemistry where the cells have expressed the CD34 and 133. So that could not be done because of the problems associated with biopsy, and we were upright to do that.
Knut from Düsseldorf, Germany. Very nice study. Thank you for the presentation. My question relates to the effect that with liver injury, the bone marrow is stimulated already so much that you don't see a lot of effect with additional stimulation. Did you measure that? Did you analyze whether stem cells or pluripotent cells were more frequent in the circulation than before your stimulation?
Actually, that's a limitation. That's a difficult thing to measure. Probably it is better done in a department of hepatology. You can see the limitation associated with it. We are not done.
Because if that doesn't add much, you can't really
I agree.
Thank you very much.
Thank you.
Thank you.
Okay, the next presenter is Dr. Flavio Mirana from Italy, who's going to talk about the role of R1 vascular resection for cholangiocarcinoma.
Good afternoon. Thank you to the organizing committee for giving me the possibility to talk about the results of our study of the role of R1 vascular resection for mass-forming cholangiocarcinoma. Okay. I have nothing to disclose. Just a second. Here we are. Nothing to disclose. So just a quick recap of the role of R1 surgery in cholangiocarcinoma. As we can see from this data from a European multicentric cohort, the R1 margin is associated with an inferior long-term outcomes in terms of recurrence and in terms of overall survival for intrahepatic, perihilar, and distal cholangiocarcinoma. However, less has been reported about the role of R1 vascular surgery, namely detaching the tumor from the vessel. In literature, we can find just a couple of papers. One is from our group in 2019, and the second one is a multicentric study from a French cohort. In both cases, R1 vascular did not elicit conclusive results compared to R0, and in particular in the multicenter cohort of the French experience, R1 vascular was associated with an increased number of postoperative complications. So the aim of our work was to analyze with a longer follow-up compared to the previous experience patients undergoing resection for mass-forming cholangiocarcinoma in our center were enrolled patients with at least 12 months of follow-up. And this is a quick recap of the different kind of R1 vascular margin we can have, the parenchymal R1 and the vascular R1 with tumor vessel detachment. But for this study, we decided to theorize a new kind of R1 vascular, the R1 vascular parenchyma, for those biggest lesions that cannot be detached in a single point from the vessel, but for technical reason, a parenchymal exposure close to the vessel was necessary. So we divided with this new concept our population, 125 patients, according to the margin in R0, R1 vascular parenchyma, and parenchyma. And this is the baseline where we can see that according to the new definition, patients in the R1 vascular parenchymal group had larger lesion as well as the R1 parenchymal, but differently from the previous experience of the French cohort, our patients did not experience a higher rate of major postoperative complication. So after a median follow-up of almost 57 months, these are the overall survival and disease-free survival curves, where we can see, despite not reaching the statistical significance, the R1 parenchymal patients showed a lower overall survival compared to the other groups. On the other hand, however, both the R1 vascular and the R1 parenchymal showed inferior disease-free survival compared to R0. But when we analyze the local recurrence, the risk of local recurrence, we can see that how the R1 vascular showed similar rates of local recurrence compared to R0, as well as the R1 vascular parenchyma. On the other hand, the R1 parenchymal showed a higher rate of local recurrence compared to R0. And when looking at the R1 patient, the R1 parenchymal patients showed a lower survival after recurrence compared to the R1 vascular. The role of margin, however, lose a little bit is predictable in terms of survival when compared with other characteristics in the multivariate analysis, where we can see as the macrovascular invasion is the independent factor for overall survival, and on the other hand, the nodal status and the bilobrar disease represented influencing factor for the disease-free survival. So we can say that, of course, with the limitation of a retrospective and monocentric study, the R0 still represents the gold standard. However, R1 vascular could be an alternative when R0 is not feasible. For example, for mass-forming cholangiocarcinoma with a complex central located presentation, showing an adequate rate of local recurrence and perioperative outcome. On the other hand, R1 vascular parenchymal may represent a needing for the largest mass-forming cholangiocarcinoma, and R1 parenchymal should always be avoided because of the increased risk of local recurrence and the reduced survival after recurrence. Thank you for your attention, and I'll take any question.
Mei T from Washington, D.C. again. Nicely presented. What does your institution do for patients who have a microscopically positive margin? Do they get referred for chemoradiation adjuvantly, intraoperative radiation? What happens to those patients?
Actually, I have to say that in our series, as it's been analyzed, there are no R2, so a macroscopic. Actually, all the cases are discussed at multidisciplinary meeting after the operation, and most of them usually undergoes adjuvant chemotherapy, considering a large amount of factors. So not only the margin, but for example, also the presence of positive lymph nodes and general characteristics. I would tell you that the R1 as a single factor, it's not the only element that define the destiny of the patient in the multidisciplinary discussion.
And did any of these patients receive neoadjuvant treatment?
None of the patients in this cohort has received neoadjuvant.
Any comment or questions? Okay, thank you very much.
Thank you.
Dr. Jain from MD Anderson Cancer Center will now present a study on prognostic factors after surgical resection of multifocal cholangiocarcinoma. Dr. Jain.
Thank you.
All right, good afternoon, everyone. Thank you for the opportunity to present. So, surgery remains the only potentially curative treatment for intrahepatic cholangiocarcinoma with a 5-year survival of about 35 to 40%. However, the prognosis after hepatic resection for multifocal disease is worse than for solitary or unifocal intrahepatic cholangio, with a reported post-op survival of under 2 years. As a result, multifocality must be carefully considered prior to an attempted resection. However, we hypothesize that there are factors that may help improve outcomes and/or identify patients with a better prognosis after resection of multifocal disease. In order to identify said factors, we retrospectively reviewed 168 patients with intrahepatic cholangio who underwent curative intent hepatectomy from 2003 to 2022. Patients with multifocal disease had increased rates of elevated CA19-9, pre-op chemotherapy, nodal disease, and post-op chemotherapy compared to patients with solitary disease. Despite the increased rates of perioperative chemotherapy, both recurrence-free survival and overall survival were significantly worse in patients with multifocal disease. The median overall survival for multifocal disease was 34 months, which is still better than what has been reported for systemic chemotherapy alone in these patients, but there's clearly room for improvement. Amongst all patients with intrahepatic cholangio, multifocality was the only factor independently associated with worse overall survival. And multifocality was also independently associated with worse recurrence-free survival alongside nodal disease and a maximum tumor size above 5 centimeters. Now, amongst just the patients who underwent resection for multifocal intrahepatic cholangio, we attempted to identify certain perioperative factors associated with improved overall survival in this high-risk population. The only factor independently associated with overall survival was undergoing a portal lymphadenectomy. All other factors, such as nodal positivity, lymphovascular invasion, margin status, and even tumor number, bilateral distribution, or tumor size, were not associated with overall survival. In conclusion, survival following resection of multifocal intrahepatic cholangio is worse than for solitary disease, but it's still better than the 12-month survival associated with systemic chemotherapy alone. Portal lymphadenectomy is independently associated with improved overall survival after multifocal disease, likely due to improved pathologic staging in the post-op setting, and potentially due to the clearance of microscopic lymph nodal disease, especially in patients who may have been clinically node negative in the pre-op setting. We believe that a select subset of patients with multifocal disease can derive long-term survival benefits. Further development of objective biomarkers like radiomics or cell-free DNA may lead to improved patient selection and oncologic outcomes. Thank you.
Saj Khan, Yale University. Very nice talk. Question about your pre-chemotherapy, pre-hepatectomy chemotherapy cohort. Did you look at that group that got chemotherapy versus no chemotherapy and saw a difference in survival or favorable survival in a multivariate analysis for the pre-chemotherapy for the chemotherapy group?
And sort of when we did our multivariable analysis for the overall survival, we did plug in those variables as well, both for all intrahepatic cholangio patients and just for patients who had multifocal but didn't find a difference based on the receipt of preoperative chemotherapy.
Pavanendra Lal from New Delhi. Nice presentation. You reinforced the well-known fact that multifocal intrahepatic cholangios fare poorer in terms of both recurrence-free and overall survival. But you mentioned about the subset of patients who do well. So could they be recognized or identified preoperatively, and is portal lymphadenectomy the only way to improve the survival? Was that what these factors proven in the study that you did?
Mm-hmm. So I'll start with the second part about the portal lymphadenectomy first. I don't think it's the only way to improve survival. There are definitely going to be other ways that we need to uncover. We did compare the survival of just those patients who had a portal lymphadenectomy and those who did not, and there definitely was like an 11-month improved overall survival. In terms of identifying preoperatively, that's essentially the goal. I think there's some other factors that we need to add to this analysis, perhaps looking at preoperative major vascular invasion on imaging and other high-risk features as well. We had most of them, but I think there's certainly other pre-op factors. And that's why I'm hoping things like maybe cell-free DNA and the use of I think future innovations can help identify those patients.
Thank you.
Great talk. I was wondering if you considered or look for any difference among patients with multifocal disease who had bilobar distribution and versus unilobar distribution of the nodule.
Great question, Flavin. Great talk yourself as well. We did actually look. We wanted to see if maybe there's a difference between having bilateral disease versus satellitosis, but we didn't find that. We even also tried to see maybe is there a difference if you had 2 tumors versus more than 2 tumors, but unfortunately we didn't find a difference there.
Thank you.
Tim Pollock, Ohio State, so great talk. So I was wondering if you looked at tumor burden score. I know like our group and others have looked at like a composite measure tumor burden score, which looks not only at number, but also size of the tumor. Because I think ultimately, you know, trying to figure out the volume of disease in the liver is important. So I'm wondering if you looked at that. And then the other thing I would just maybe caution around like folks leaving thinking like, if I do a lymphadenectomy in somewhat multifocal disease, I'm going to improve their survival. I think it's incredibly problematic and difficult to prove causality relative to long-term outcome in retrospective studies. And so I question a little bit the therapeutic value of a lymphadenectomy, although I think all patients should have it for staging purposes.
That's a great question, Dr. Pollock. We didn't use the tumor burden score, but it would be good to, I think it's something that we definitely could do because we did have like the size and maximum tumor size for all these patients. I mean, definitely in our prospective database for the patients who have multifocal disease do have the size of each individual tumor. In regards to your comment about causation, that's a great point. You shouldn't, obviously we're not saying that portal lymphadenectomy is the way to go and that this is going to improve everyone's survival, but it's, I think more so what I would say is that in these patients who have high risk disease, I think it is something that you should do. It may not necessarily have a clearance of disease effect. It's just a theory that needs maybe a prospective trial to be proven, but it can definitely help with pathologic staging postoperatively and is something that should be strongly considered in these patients.
So if it's not routinely used in your practice, which patients do you decide to do a portal lymphadenectomy on?
That's a great question. So in our practice, we, this study like spanned a very long time period, but more recently in our practice, we do try to do a portal lymphadenectomy for patients with, quote, high-risk features, multifocality, at least 5 centimeters in size, any pre-op vascular invasion. We definitely like try to do a purposeful, adequate portal lymphadenectomy on those patients, and of course, for other patients, I think, given the circumstances of the surgery, but in those high-risk patients, we're definitely very purposeful about it.
Great, thank you.
Okay, thank you very much.
From Dr. NHÂN from MD Anderson. Presentation is Variations in Liver Vascular Anatomy and Implications for Hepatectomy.
Thank you for the opportunity to present today. We have no relevant disclosures. Although hepatic, arterial, and portal venous anatomy have been described, a comprehensive evaluation of hepatic vascular anatomy that includes other critical elements relevant to hepatectomy is lacking. Therefore, the purpose of this study was to thoroughly characterize these hepatic vascular variations and measurements that inform surgical planning. Our study included 759 patients who underwent hepatectomy at our institution between June 2019 and December 2022. They must have had a high-quality CT abdomen pelvis with thin axial cuts prior to liver resection. For these patients, we performed a comprehensive evaluation of hepatic arterial, portal venous, and hepatic venous anatomy as detailed here. Starting with hepatic arterial anatomy, we found that overall 67% of patients had a normal hepatic arterial anatomy with the right and left hepatic arteries arising from the proper hepatic artery. There was a replaced right hepatic artery or an accessory artery arising from the SMA in about 16% of patients. For patients who had a non-aberrant right hepatic artery, we evaluated this position relative to the common hepatic duct. This would be relevant, for example, during the bile duct dissection for a hilar cholangiocarcinoma, or if the right hepatic artery needs to be isolated. In a majority of patients, about 79%, the right hepatic artery coursed posterior to the common hepatic duct. In 19%, it was anterior, and about 2%, there were branches both anterior and posterior. Additionally, we noted a variant of the right hepatic artery that arose directly from the celiac trunk, so not truly replaced, but took a course similar to a replaced right hepatic artery from the SMA, posterior to the bile duct. This variant was present in 2.6% of patients, either as the only right hepatic artery or as an accessory artery. The replaced left hepatic artery arising from the left gastric artery or an accessory artery in this location was present in about 19% of patients. We next evaluated the portal venous anatomy. The portal vein anatomy was normal or type A in about 83% of patients. In this type A configuration, we measured the length of the right portal vein, relevant for dividing the right portal vein during a right hepatectomy, for instance. The median length was about 2 centimeters. In about 10% of patients, this length was less than 1 centimeter. And in these cases with a very short right portal vein, possibly the right posterior and anterior branches may need to be taken separately. In about 7% of patients, there is trifurcation of the left, right anterior, and right posterior portal venous branches. And in another 7% or so of patients, the portal venous anatomy was staged with earlier branching of the right posterior portal vein. Finally, we evaluated the hepatic venous anatomy. First looked at the presence of accessory hepatic veins on the right side. So the presence of a right inferior hepatic vein potentially becomes important for tumors involving the main right hepatic vein, which could then be sacrificed if it has sufficient drainage through a sizable inferior hepatic vein were present. About 30% of patients had at least one right inferior hepatic vein measuring about 5 millimeters or more. Another consideration is a late draining vein near the main right hepatic vein draining directly into the IVC. When such a vein is present, care must be taken in encircling and dividing the main right hepatic vein so as not to injure this adjacent vein. This vein was present in about 20% of patients. We evaluated segment 5 and 8 venous tributaries into the middle hepatic vein, relevant during parenchymal transection in a right hepatectomy, for instance. Most commonly, there were either 2 or 3 major tributaries. We also measured the distance between the last segment 8 vein and the hepatocaval junction. The median distance was about 1 centimeter. And in nearly half of the patients, the distance was less than 1 centimeter. And about 17%, a segment 8 vein drained directly into the IVC adjacent to the middle hepatic vein. For the left hepatic vein, we looked for the presence of an accessory left hepatic vein draining separately into the IVC from the main left hepatic vein. This was present in about 18% of patients. In conclusion, hepatic vascular anatomic variations are common, and high-quality imaging is critical for precisely defining these variations. Careful assessment of these vascular elements is needed for expert and safe performance of liver surgery. Thank you, and I'm happy to take any questions.
I think this nice presentation, by the way, this underlines or emphasizes the necessity of a thorough preoperative resection planning, looking at anatomical variants, making your resection much safer.
Yeah, absolutely agree. And getting a high quality imaging prior to resection and forming that surgical planning is critical for safe surgery here.
Do you use 3D models or 3D prints of the liver?
We do not do that routinely, but everybody does get a high quality CT scan within cuts and thorough evaluation.
Regarding the anatomy, it's equally important for pancreatic surgery. And there what you must see is where does the the replaced right hepatic, where does it rise from the SMA? If it rises from the SMA close to its origin from the aorta, it is almost like a normal right hepatic artery. It doesn't cross your field of resection. But when it rises lower down, on the superior mesenteric artery. It will cross through the neck of the pancreas, and there you have to be careful that you don't injure the right hepatic when you're doing the pancreatic dissection.
Yeah. Thank you.
Good presentation. Thank you.
Thank you.
So much.
Okay, the next presenter is Dr. Sherban from UCSD, who's going to talk about our multi-center international study on patients with T3 and T4 category of gallbladder cancer.
Thank you for this opportunity to present my research. I have no disclosures. Gallbladder cancer is a rare GI malignancy, constituting 4% of cases globally, but up to 95% of biliary tract cancers. The prognosis of gallbladder cancer heavily depends on the stage of disease and the depth of tumor invasion. Patients with T3, T4 disease have a 5-year survival between 10 and 30%. Although surgical resection is the only curative treatment, there is an ongoing debate about the optimal extent of surgery and the use of chemo and radiotherapy. This cross-sectional study collected data from 7 countries and 17 institutions, including 1,075 patients. Malignancy characteristics were documented from the initial cholecystectomy, and information on treatment modalities was gathered to perform survival analyses. The figure to the left shows the presence of positive margins among T3 and T4 patients, with T4 patients having a significantly higher rate at 32%. Overall morbidity and severe morbidity were also analyzed, revealing significant differences. T3 patients had a higher overall morbidity, while T4 patients had a higher severe morbidity at 46.3%. In this univariable Cox model analysis, it was observed that major resection provided no survival benefit for T3 patients. T3 patients, however, who received neoadjuvant and adjuvant chemotherapy had improved survival outcomes, while preoperative radiotherapy provided no benefit. R1 status and overall morbidity were associated with worsened survival. In this multivariable analysis, R1 status was the only variable for T3 patients to significantly impact patient survival. This figure demonstrates the impact of tumor category and morbidity on overall survival. T4 patients had poorer survival rates than T3 patients, and the trend indicates that morbidity worsens survival. In conclusion, major resection does not benefit T3 and T4 patients as shown in the univariable analysis. Moreover, extended surgery increases morbidity, which in turn may contribute to worsened survival. T3 patients benefited from neoadjuvant chemotherapy and adjuvant chemoradiotherapy, whereas T4 patients did not show any benefit from these interventions. Based on our study, overintervention is frequently practiced, often resulting in harm, without providing significant benefit to the patients. It is crucial to carefully consider interventions for T3 and T4 patients to minimize morbidity and maximize quality of life, given the limited time these patients have. Thank you.
Thank you very much. Any comments or questions from the audience? So what the optimal treatment strategy based on this data? What do you think about
What is the optimal
strategy of treatment for T3 and T4 gallbladder cancer?
Well, we see that chemotherapy and chemoradiotherapy help in the neoadjuvant setting, and I think it requires a multidisciplinary team to really create a certain treatment regimen per patient. So it's not really like a standard practice that should be performed, but we do see that radiotherapy does not benefit patients in the adjuvant setting.
Any other comments or questions? Okay, thank you very much for that nice presentation.
The next talk is on the impact of perioperative COVID on patients undergoing HPV surgery. And the presenter is Dr. Valdelase from Howard University.
Good evening. Thank you for the opportunity to present. My name is Terhaz Willeselassie. I'm a surgery resident at Howard. We have no disclosures. The emergence of COVID-19 pandemic in March 2020 had significantly impacted both patients and hospitals, leading to notable decrease in elective procedures. While prior studies have shown that COVID is related with increased surgical strain and increased overall perioperative risk, there is a gap in understanding its effect on hepatobiliary and pancreatic surgery outcomes. So the aim of our study was to determine perioperative outcomes and hospital resource utilization in patients undergoing elective hepatobiliary and pancreatic surgery who were diagnosed preoperatively or within 30 days of their operation with COVID infection. So we utilized data from the American College of Surgeons National Surgical Quality Improvement Project, NSQIP, from 2021 to 2022. The study focused on patients who underwent major hepatectomy or pancreatectomy as defined by the current procedural terminology or CPT codes. Patients were stratified based on their perioperative COVID-19 infection status, defined as either diagnosed preoperatively or within 30 days postoperatively. Univariable and multivariable analysis were utilized to examine the association between perioperative COVID infection and 30-day outcomes, including respiratory complications such as pneumonia, failure to wean off mechanical ventilation after 48 hours, or unplanned reintubation, thromboembolic events, including PE or DVT, bleeding events, or septic complications, as well as hospital resource utilization, length of stay, readmission, discharge to destination other than home, and also mortality after 30 days of operation. So among the 30,121 patients included in our analysis who had elective hepatobiliary and pancreatic resections, 533 patients were diagnosed with perioperative COVID-19 infection. There were no significant differences observed between COVID positive and COVID negative patients in terms of sex distribution, race, ethnicity, gender, or BMI. Notably, patients who had COVID had a higher prevalence of diabetes, 31.7% versus 24%, and they were also more likely to be functionally dependent. In a univariable analysis, COVID-positive patients had significantly higher rates of respiratory complications. They also had a higher risk of venous thromboembolism, higher risk of postoperative blood transfusion, higher risk of sepsis or septic shock, and higher risk of prolonged length of stay, higher risk of discharge other than home, and also higher risk of readmission compared to patients who are COVID negative. In multivariable analysis, now adjusting for relevant confounders. Again, perioperative COVID-19 infection remains significantly associated with higher odds of respiratory complications, post-op VTE, post-operative blood transfusion, sepsis, and also the other measure of hospital resource utilization, length of stay, discharge to a setting other than home, and readmission. And all of this had an odds ratio of more than 2 or 2 odds ratio, which increases twofold increase in complication compared to patients who are negative. So in conclusion, perioperative COVID-19 infection is associated with a greater than twofold odds of respiratory, septic, and VTE complications in patients undergoing major hepatobiliary and pancreatic surgery. Moreover, there is significant hospital resource utilization associated with perioperative COVID-19 infection with respect to prolonged length of stay in hospital, discharge to facility other than home, and unplanned readmission to hospital. So careful attention to respiratory symptoms is warranted for these patients, particularly as routine preoperative COVID-19 testing and hospital mask mandates are relaxed. Thank you, and I'll be happy to answer any questions.
Thank you very much. The paper is open for discussion. We're lagging 10 minutes behind. If there are no questions, then I would like to move on. Thank you very much.
Our next presenter is Dr. Abdullah Atlif from the Ohio State. The presentation will be on development of an artificial intelligence-based model to predict early recurrence of neuroendocrine liver metastasis following resection.
So, good evening, everyone. My name is Abdullah Altaf. I'm a research fellow at The Ohio State University. I'm pleased to be here to present our research on development of an artificial intelligence-based model to predict early recurrence of neuroendocrine liver metastasis following liver resection. I don't have any disclosures. So, liver resection has been considered as the cornerstone of treatment for patients with neuroendocrine liver metastasis, and 5-year overall survival is as high as 60 to 80%. However, post-operative recurrence is a major concern, as almost 50 to 95% of the patients have been reported to develop recurrence. Median time to recurrence has been reported to be around 15 months, and 1-year recurrence-free survival is less than 60%. Therefore, prediction and management of recurrent disease, particularly within first 12 months following surgery, is crucial. So, in the current study, we sought to utilize different machine learning and deep learning algorithms to predict early recurrence of any LM following liver resection. For the study, we utilized a multi-institutional database comprising 12 major hepatobiliary institutions worldwide. We excluded patients who had unresected primary neuroendocrine tumor who received only liver ablation therapy, who had extrahepatic disease at the time of surgery, who had R2 resection margins, and who died within 30 days of liver resection. Early recurrence was defined as recurrence within 12 months of surgery, and we used the following machine learning and deep learning algorithms to predict early recurrence. And then we compared them using ROC curve analysis. So in total, we had 473 NELM patients on median follow-up of 55 months. Almost 60% of the patients developed recurrence, and out of those patients, almost 40% developed early recurrence. These patients were randomized with a ratio of 8:2 into training and testing cohorts, which were both evenly matched. So overall, median age was 58 years and equal percentage of male and female patients. Median tumor burden score of NELM was 5.7. Most of the patients had well-differentiated tumors, and perineural invasion was seen in 9.3% of the patients. So as we can see in the ROC curve, the ensemble model that consisted of gradient boosting machine classifier and multi-layer perceptron demonstrated the highest accuracy, and it achieved an AUC of 0.716 in the testing cohort. And we employed the SHAP algorithm to compute factor weightages to predict early recurrence. And as we can see in this bar graph, maximum tumor diameter of the primary neuroendocrine tumor, neuroendocrine liver metastasis, radiologic tumor burden score, and number of liver lobes involved by NELM were the three most significant factors. We did Kaplan-Meier survival analysis, and patient predicted to develop early recurrence had worse 1, 3, and 5-year survival as shown on the slide. So we deployed this machine learning algorithm online for its wide application, and you can get each patient's probability of developing early recurrence. So we can say that the application of AI to predict early recurrence of NELM demonstrated strong performance. So our AI-based model can be used to risk stratify patients according to their prognosis and inform tailored surveillance strategies. And lastly, for utilization and decision-making for consideration of other treatment options like intra-arterial therapy. Thank you so much. I'm happy to take any questions.
Hi, Rajat Narayan from Dana-Farber, Mass Gen Brigham. I'm the invited discussant. Thank you for sending your slides and the manuscript in advance. This is an excellent presentation and just excellent display of work from your group overall in this session as well. 2 quick questions given the time. So the first is I noticed using early recurrence as your metric for devising the model, it doesn't take into account patients that were censored like you would think of in a classic biostatistical analysis where you would consider disease-free survival or recurrence-free survival. Is there another modality that you could use with your machine learning algorithms to incorporate time-based variables to make sure you're not overseeing patients that may have been missed because we just don't know if they recurred or not? And my second question is, we've seen a number of these excellent online calculators made from your group as well. I'm curious about how these are implemented in decision-making for your patients at your institution, since unfortunately all of the factors that were on the model are not able to be altered by the provider, other than perhaps smoking, which by that point, the damage has been done. Does that help you decide whether you should use somatostatin analogs or some other difference in terms of your approach of going to the OR for these patients or not?
Okay. So thank you so much for the questions. So for your last question, going forward, we need to externally validate this model and also prospectively before incorporating it into clinical practice. But this can be definitely included in multidisciplinary team meetings for consideration of treatment options, particularly if some patients' risk of early recurrence is very high, then you can go for other treatment options like TACE for them. And secondly, we can use this calculator to discuss with the patient. We can show to them that what's their exact probability of developing early recurrence. So it just helps in patient-doctor communication. And coming to your first question, it would be nice to do this with a larger database to only include patients who have 12 months of follow-up duration, so that we know in those 12 months how many of these patients develop recurrence. But if we do that, then we couldn't do that because we had a small number of patients. But going forward, having a larger database where we have a follow-up of at least 12 months, so that would be good to go forward. But yeah, thank you for that question.
I think if anyone can do it, it's your group because you have multiple centers that are collaborating, so probably a follow-up study at some point.
Yeah, that would be done. Thank you.
I have one more question. Is the individual result of this analysis something that you reveal to your patient when you get the informed consent and when you talk about the surgery?
So we just did the study, but what we can do is when patient come to the office, we can. So this model tells you the exact probability that the patient can have early recurrence. So rather than saying you can develop recurrence or not, it just tells you have 80% chance to develop early recurrence. So it basically gives you the exact prognosis for the patient.
Okay.
Thank you.
Thank you so much.
Thank you so much.
The next paper is about the efficacy of ERCP test to reduce the risk of viral leaks and organ space infections, presented by Dr. Dix from MD Anderson Cancer Center.
Good afternoon. Thank you very much for the opportunity to discuss my work. I have no disclosures. So surgical drain placement following hepatectomy is common practice, but is drain placement always necessary? Now, we know that a lot of patients don't receive drains, but a number of patients are still receiving drains, and we put into question whether or not that was necessary. A recent meta-analysis suggested that drains were not beneficial even after major liver resections, and a recent study also suggested that in low-risk patients, these drains could actually be deleterious and were associated with infectious complications and postoperative bile leaks. At our institution, we perform an air leak test whenever possible to detect bile leaks early. We inject air via the cystic duct and submerge the resected margin of the liver under water. Bubbles aid us in detecting bile leaks and allow for immediate repair. We hope that this can mitigate mitigate complications and the possible need for drains. In one of our studies, we demonstrated that this air leak test reduced bile leaks from 11% to 2% postoperatively and organ space infections from 13 to 5%. In this study in particular, we aimed to evaluate whether or not surgical drain placement following the performance of an air leak test was associated with rates of post-hepatectomy bile leak and organ space infection that, for the sake of this presentation, I'll call postoperative complications. We prospectively queried our quality improvement database of hepatectomy patients over 6 years. And our patients were risk stratified preoperatively into high risk versus low risk using the Kawaguchi-Kaye classification. Bile leaks were defined as grade 3 or greater requiring intervention, and organ space infections were defined as deep surgical infections also requiring intervention. We assessed for performance of air leak test and also for drain placement. We excluded any combined operations. We found 1,106 patients who underwent procedures, including 705 low-risk and 401 high-risk patients. Of these, 22% of the low-risk patients underwent an air leak test, and 63% of the high-risk patients underwent an air leak test, so almost 3 times as common. Drain placement was 4 times as common, 6% in the low-risk versus 24% in the high-risk. And bile leak and organ space infections were seen in 3% of the low-risk patients versus 8% in the high-risk patients. When we looked at our overall cohort, there was no significant difference between those that did or did not have postoperative complications in terms of patient demographic characteristics, disease characteristics, or pre-resection treatment characteristics. On the other hand, and not surprisingly, those who underwent low-risk resections, Kawaguchi-Kaye 1 or 2, had fewer bile leaks and organ space infections. On the other hand, those that underwent more numerous resections, particularly those that underwent more than 2 resections, were more likely to have a bile leak or an organ space infection. We first looked at our high-risk cohort, and in this cohort, there was no difference in postoperative complications whether or not they had an air leak test performed. However, drain placement itself was associated with an increased risk of postoperative complication. We then performed a multivariate analysis with different reference groups, and in patients that did not have an air leak test, drain placement was associated with an increased risk of postoperative complications. However, when we used a reference group of patients that had undergone an air leak test, drains were no longer associated with postoperative rates of complication. When we looked at our low-risk cohort, we found the same finding with regards to air leak tests, which was that there was no association directly with bile leak testing and organ space or bile leak. On the other hand, drain placement itself was associated with a significantly higher rate of bile leak and organ space infections. When we used the reference group of patients that had not undergone bile leak testing using an air leak test, there was a significantly higher risk of bile leak and organ space infection in patients that had a drain placed. On the other hand, once again, when an air leak test was performed, this was no longer true. In conclusion, we underline the importance of risk stratifying patients into high risk or low risk preoperatively during preoperative planning. Air leak tests can help identify occult bile leaks, and they can be repaired immediately, which can mitigate the risk of long-term complications and can help reduce the need for postoperative drains. And importantly, what this study shows is that when an air leak test is performed, or any bile leak test we suggest, drain placement is no longer associated with bile leak or organ space infection rates postoperatively. So in low-risk patients, if there's any concern, we strongly urge surgeons to consider performing either an air leak test or another form of bioleak testing, and this can reduce the need or abrogate the need for any drain placement postoperatively. Given the complex factors for high-risk operations, we're not making any recommendations about high-risk patients, and we do acknowledge that further studies are warranted to delineate the role of drains in high-risk patients. Thank you very much. I'll take any questions.
Very nicely presented. Mei T from Washington, D.C. So a comment and a question. For things like robotic surgery, an air leak test is really difficult. And so, often you're using things like ICG or other metrics to look at whether there's bioleakage at your parenchymal margin. What do you guys do with your drains? There is a lot of data suggesting that drains can be highly morbid and can cause leaks. Do you put them to closed suction drainage, or is it just to like a billy bag, like where there's no suction on the drain at all? I'm just curious.
Yeah. Thank you very much. So we absolutely agree. Our concern is that these drains do actually have deleterious effects because they may be contributing to the formation of fistulas and bioleaks and subsequent infections. These drains are commonly placed, these drains are not stripped, but are commonly placed to bulbs, sometimes to gravity. That depends on the surgeon. But we urge nursing staff and the care provider team not to strip these drains. We try to remove them early whenever they're placed.
Thanks. Really nice presentation. And I think, a technique that your group has published a lot about and is fairly reproducible. In light of this, can you just talk a little bit about your algorithm for you do the air leak test is positive, who ends up getting a drain, who doesn't, and sort of that decision-making process so those of us who aren't emanating from Anderson can adapt into our practice?
That's a great question. Thank you very much, Dr. Conker. So I think that in low-risk patients in particular, given the size of the resections, if you do identify a bioleak, which you may well, the idea behind the air leak test is that you can address this leak immediately. Once you've addressed it and repaired it, you can re-perform an air leak test. And if you don't see any leak, the idea is to not leave a drain. And hopefully, if you're performing a bioleak test, then you can repair this. In higher risk patients, if you have a high degree of suspicion that your repair may not be complete or that you have recurrent positive air leak tests, that's the time where placing a drain may be reasonable. But again, the concern is that these drains may contribute to this and should be removed in an expeditious manner, even in high-risk resections. Thank you.
Thank you.
Thank you very much.
Thank you very much.
So our last but one talk is about robotic liver surgery in the difficult liver segments. And the talk is presented by Dr. Jones from West Florida. Dr. Jones.
Sorry, good evening. So today we are presenting the difficult resections when compared during the robotic liver surgery. Those are the segments 7, 8, 4A, and caudate lobe. So we have no disclosures. So we all talk about this MIS in the HPB surgery has reduced blood loss, shorter ICU stay, decreased hospitalization, and diminished postoperative complications. And more we are adopting the robotic platform in the HPB surgery. So when we do the hepatectomies, they range from simple lateral sectionectomy to the complex robotic resections involving the posterior segments or isolated caudate lobe resections or en-bloc caudate resection along with the right/left lobe. So we in this study we want to compare the outcomes, and we all know that even the difficulty scoring systems assign highest points for the segment 7, 8 for the caudate lobe. And the three most difficult hepatectomies we picked from our cohort is the en-bloc caudate resection with the right and left hepatectomies, isolated caudate resection, and posterior superior segment resection. This is the standard port placement for the posterior superior segments. We move the umbilical port to the right mid-clavicular line, close to the liver margin, so that the access to the posterior segments will be much better than the standard port placement. So we have 500 robotic hepatectomies in our institute from 2013 to 2024, out of which we collected these difficult resections, and all the planned open procedures were excluded. And the data is presented as median, and one-way analysis of variance is used to describe the differences between each groups. The preoperative variables are like age, sex, BMI, history of prior abdominal procedures, presence of cirrhosis, MELD score, Child-Pugh score, presence of prior liver resections. Intraoperative variables, we calculated operative duration, EBL, unplanned conversions to open, intraoperative complications, tumor size and margin, resection margin. Postoperative variables, we calculated the postoperative complications more than Clavien Dindo 3, readmissions within 30 days, in-hospital mortality, 90-day mortality, and length of stay, and mean follow-up. So the total number of patients are like 215 with the posterior superior segments around 131, isolated caudate lobes are 19, and en-bloc caudate resections are like 65. Total males are 102 and total females are 113. Prior abdominal procedure is present in 122 patients. MELD score, average MELD score is 7, Child-Pugh score is 5. Cirrhotic patients are 29 in this group, and prior liver resections happened in 27 patients. A neoplastic liver disease is present in 156 patients, and 48 patients received neoadjuvant chemotherapy. So if you see, the operative duration correlated well with the en-bloc resection, having the highest op time, around like almost 6 hours, and least time for the isolated caudate lobe resection, and it reached the significance. The EBL is also highest in en-bloc resections with around 200 cc, and least in the isolated caudate lobe resection. And postoperatively, the length of the stay is more in the en-bloc resections. And from the other original cohort, we found the cirrhotic patients have high 90-day mortality, which reached the level of significance. So we calculated the 1 and 3 year survival with the Kaplan-Meier curve, and we found the tumor pathology follows a similar trend irrespective of the resection or robot is used. So we finally conclude that en-bloc caudate resection or like isolated caudate resection is possible with a robotic platform and have significant outcomes that won't affect any survival benefits. So we recommend proceeding with the robotic resection of the caudate lobe or en-bloc resections after achieving adequate skill set. Limitations, it's short follow-up and a single institute, single surgeon study. But the conclusion is like we recommend, but we need much multi-institute study to confirm the finding. I'm open to questions.
Great, thank you.
Thank you very much. There's a question from the floor.
Hi, Seth Concourse. One quick question. You talked a bit in your conclusions about how these are feasible. These are probably very technically challenging operations, but you didn't talk a lot about the learning curve over time. Did you at all do analysis of complication rate over maybe the first couple and iteratively?
So yeah, we have the other abstract coming showing the learning curve, but we initially divided our procedures: initial phase, intermediate phase, and advanced phase. And most of these resections happened in the advanced phase, which is after almost like 300 of his robotic hepatectomies.
Sorry, in the interest of time, we'll save questions for the end. Thank you. Thank you. Our very last presentation is from Dr. Ashley Gao from Indiana University. She'll be presenting about ERCP for management of post-cholecystectomy bowel leaks in patient with subtotal versus total cholecystectomy.
Good afternoon. Thank you for the opportunity to present. Laparoscopic subtotal cholecystectomy is an established approach for difficult cholecystectomies as a strategy to mitigate risk for complications such as bile duct injury. Incidence of bile leak is higher following subtotal cholecystectomies at 12 to 18% compared to total cholecystectomies at 1%. ERCP with biliary sphincterotomy with or without bile duct stent placement is the most effective intervention for post-cholecystectomy bile leaks. With increased adoption of subtotal cholecystectomy for complex cases, a comprehensive understanding of the effectiveness of ERCP for bile leaks in this setting is imperative. We identified patients referred to IU Health University Hospital from 2011 to 2021 for ERCP management of bile leaks. We included patients with identified Strasburg A bile leaks and or leaks from the gallbladder remnant. We excluded bile leaks from other etiologies such as hepatectomy or trauma, as well as complications such as common bile duct injury. Operative reports, ERCP choleangiograms, and cross-sectional imaging were reviewed to verify subtotal versus total cholecystectomy status. We defined high-grade bile leaks as bile leaks identified before intrahepatic duct opacification on retrograde cholangiography. 301 patients met our study criteria, and demographic differences between the cohorts is as expected. Patients managed with subtotal cholecystectomy were older and had higher BMIs, which likely correlates to a higher comorbid status. Additionally, bilomas were less frequently found in the subtotal group, likely related to the fact that a percutaneous drain was more frequently positioned at time of surgery. Intraprocedural findings, including rate of high-grade bile leak, were similar between groups. There were some differences in management strategies with more covered metallic stents, which were placed at the discretion of our ERCP physicians, and a longer stent dwell time in the subtotal group. I would like to emphasize that rates of metallic stent placement was overall low between the two groups and not the strategy elected in the majority of subtotal cholecystectomy patients. While there was a trend for persistent leak at follow-up ERCP in the subtotal group, this was not statistically significant, and median number of ERCPs required to resolve bile leaks were similar between groups. Overall, the success rate of leak resolution with ERCP was very high, and 100% of patients in the subtotal cholecystectomy group were able to be managed with ERCP alone. ERCP remains a highly effective strategy for resolution of bile leaks in patients after subtotal and total cholecystectomies. The use of metallic stents and an extended dwell time was more frequent in patients with subtotal cholecystectomies. However, there were no differences in ERCP procedure burden or success rates for bile leak resolution between the two groups. This was a retrospective study, and as such, details regarding the decision-making process behind metallic stent placement and longer dwell time in the subtotal group is missing, and our ability to recommend an algorithm with stent management is limited. This is a single-center study by expert endoscopists. However, the rates of success and outcomes may vary when applied broadly. This concludes my presentation. I'd like to open the floor to questions.
Hi, Roger Narayan from Dana-Farber, Mass. Brigham. I'm the invited discussant. Thank you for sending your slides in advance, Dr. Gao. This was a great presentation to close out the session. Two quick questions. So first, you mentioned that patients with subtotal cholecystectomy were able to be managed with ERCP, but because they had drains placed initially and they did have a fair number of percutaneous drains placed, I'm curious if you looked at the number of overall interventions that were done after the index readmission for bile leak, and if that was more or not significantly different between leaks from total and subtotal. And second, when I was a junior resident consenting these patients, we didn't commonly talk to patients about the possibility of a subtotal cholecystectomy. It's more commonly done now as a salvage maneuver, especially in high-risk cases. I wonder if your institution has changed your practice and how you talk to patients about the likelihood of this happening and how that changes the effort in the OR versus the expectations of the patient.
Right. To answer your second question first, at our institution, we do consent for a laparoscopic cholecystectomy, and the decision to do a subtotal versus total is up to the discretion of the surgeons at the time of operation based off the intraprocedural findings. Whether or not they get counseled about it potentially turning into a subtotal procedure, I'm not clear on as part of the conversation. And then regarding your first question, the number of procedures total after index ERCP, we have not been able to look at yet. However, I do note that a significant proportion of the drains were left at the time of surgery, and not a significant amount were novel IR procedures after that time.
Great, thank you.
Thank you very much.
Thank you.
We would like to thank all speakers for submitting and presenting, and we would also like to thank the podium for your discussion. We are only 15 minutes late for such a densely packed session, so I think that's not too bad. We wish you a pleasant evening and a good meeting. Thank you very much.